Good afternoon, everybody, and welcome to this afternoon's meeting of the Lincolnshire Health and Wellbeing Board. My name is Councillor Steve Clegg, and I'll be chairing today's meeting. However, our usual Vice Chair, Claire Raybould, is unable to attend due to illness. Under this board's terms of reference, a nominated representative from the ICB is required to be here, and I'm pleased to welcome Fergus Mack, Associate Director, Planning and Transformation, who will be present for this meeting. Thank you. I'd like to start with the ever-important health and safety announcement. There is no fire drill planned this afternoon. In the event of a fire alarm sounding, we will need to leave this council chamber through the rear doors and leave the building through the reception in the front car park. We will then need to wait in the car park for further instructions. Can I please remind everybody to switch their mobile phones and other devices to silence? And also, when invited to speak, can you please ensure that you switch on your microphone? Otherwise, those attending the meeting via Teams or members of the press and public listening to our meeting online will not be able to hear you. Please be aware that you need to speak directly into the microphone to be heard. If you wish to speak during the meeting, can you please raise your hand, and Jess will be able to collate your request to speak. So we'll move on now to item 1, apologies for absence. Jess.
Thank you, Chairman. We've received apologies from Councillor Karen Lee, Councillor Paul Locke, Joanne Davison, Kevin Lockyer, Chris Davison, Elaine Baynes and Dr. Kevin Thomas. We have Fergus Mack replacing Claire Raybould, and we have Linda Dennett replacing Heather Sandy. Thank you.
Thank you, Jess. We'll move on to item 2, declaration of members' interest. Are there any members who would like to declare an interest for any of the papers? No. Well, if during the meeting you realise that you do need to declare, then please indicate and we'll make sure that it is noted. So now moving on to item 3, minutes of the previous meeting held on the 9th of December 2025. This is to confirm the minutes of the meeting held then are an accurate record, and these can be found on pages 5 to 8 of the agenda pack. Do I have any comments from anybody? Could I have a proposer? Councillor Cullen, and a seconder? Martin Samuels. Okay, so if I could have a show of hands, all those in favour? Any against? Any abstentions? Those minutes are agreed, thank you. So we now move on to action updates, item 4. You're invited to note the action updates on pages 9 to 10 of the agenda pack, and these are for noting. I'd like to ask if all the members agree by a show of hands, please. Any against? Those actions are duly noted. I now move on to item 5, Chairman's announcements. These announcements are on pages 11 to 12 and are for noting. And if members may allow me to indulge briefly, I'd like to refer to a couple of items relating to 2 people mentioned in my announcements. First of all, I'd like to, on behalf of the board, the Health and Wellbeing Board, welcome Professor Trudy Grant as the Interim Director of Public Health for Lincolnshire. Welcome aboard. Trudy began her career as a sport and exercise scientist before moving into public health, where she has built a distinguished career. She has previously served as the Director of Public Health for Somerset, so welcome, Trudy. My second person, I'd like to mention the retirement of the Chair of the Lincolnshire Community and Hospitals NHS Group, the LCHG, Elaine Baynes, She will be retiring from her role as the Lincolnshire Community and Hospitals NHS Group. Elaine also served as an associate member of the Health and Wellbeing Board since 2019, and I'm sorry she's unable to attend today's meeting, but if I may, on behalf of the board, I'd like to thank her for a valuable contribution to the health and care of people in Lincolnshire. Thank you. So moving on to the substantive business on the agenda, item 6A, the NHS Joint Forward Plan, which can be found on pages 13 to 18 of the agenda pack. And this invites the board to note the requirements for NHS integrated care boards to develop a joint forward plan. I would therefore like to invite Fergus Mack, the representative from the DLN cluster, to present the report. Thank you.
Thanks very much, Chair. So this report provides the Lincolnshire Health and Wellbeing Board with an overview of the NHS Lincolnshire ICB statutory responsibilities in developing a joint forward plan and how we're meeting these duties through the Derbyshire, Lincolnshire and Nottinghamshire ICB cluster. I'm just going to summarise the salient points in the report and then pick up any questions. So just to remind colleagues of the statutory context, so ICB's been required to maintain a 5-year forward plan that demonstrates how the system will improve outcomes, reduce health inequalities and give proper regard to the Lincolnshire Joint Health and Wellbeing Strategy and support delivery of its priorities within NHS planning and commissioning. Clearly, the last year has seen initiation of wide-ranging reform of the NHS and the healthcare landscape, specifically pertinent to this 10-year health plan, which came out in July 2025, which outlines a strategy to reform the NHS through 3 main shifts: moving care from hospitals to communities, transitioning from analogue to digital, and focusing on prevention. It also signals a new NHS operating model. This includes integrated care boards significantly reducing their running costs and focusing on strategic commissioning. The other key point to note is the publication of the NHS England Strategic Commissioning Framework in November, which sets out expectations for integrated care boards using a defined commissioning cycle. So in response to this policy developments, the Derby and Derbyshire, Lincolnshire and Nottinghamshire ICBs have come together to achieve efficiencies at scale through a cluster arrangement, and the DLN Integrated Care Board cluster produced 2 distinct but very connected products relating to its joint forward plan duty. The first of which is a 5-year population health strategy, which sets the overarching population health ambitions and outcomes, and then linked in with that there's a 5-year strategic commissioning plan which translates those strategic ambitions into commissioning intentions, delivery mechanisms and measurable outcomes. So turning strategy into reality is the aim of that document. So together, those 2 documents replaced the previous joint forward plan, but clearly previous joint forward plan integrated care partnership strategy informed the development of those. Just picking out the specifics where there are clear connections between the Derbyshire, Lincolnshire, Nottinghamshire ICB cluster plans and the Lincolnshire Joint Health and Wellbeing Strategy. These include population health outcomes based around the life course approach and rooted in the Joint Strategic Needs Assessment. The strategic and commissioning priorities very much mirror the Lincolnshire Joint Health and Wellbeing Strategy themes such as prevention, early intervention and tackling inequalities. The key performance indicators for the strategic priorities in the population health strategy are very much aligned to the we will statements in the Lincolnshire Health and Wellbeing Strategy. Neighbourhood-based models are the primary delivery mechanism to integrate care and improve access, and the cluster will actively invest in partnership development to evolve the broader interventions, i.e. the sort of non-core NHS that will support delivery of both the population health strategy and and Lincolnshire Joint Health and Wellbeing Strategy priorities. So once the DLN ICB cluster population health strategy and strategic commissioning plan have gone to the public DLN ICB cluster board in March, which is next week, they'll be available to share wider with partners to support the development of joint plans. So in summary, Chair, this report aims to provide assurance that the DLN ICB cluster has produced a coherent set of documents that serve statutory forward planning purposes while also meeting NHS England expectations of ICB as strategic commissioners, and NHS planning is taking full account of Lincolnshire's joint strategic needs assessment and joint health and wellbeing strategy as required under the Health and Care Act 2012.
Thank you, Fergus. That's very succinct. Thank you for that delivery of that report. Do we have any questions? Martin Samuels.
So I'm conscious that where I'm sat, I'm going to ask Fergus a question and have my back to you, but that's the way the layout of the room. So obviously the new cluster covers a very, very large geographical area. Lincolnshire represents more than half of that in terms of geographical area, but perhaps only about 20% of the population. So you talked, Fergus, about the population health strategy and the strategic commissioning plan, and I think clearly those documents are required for the cluster. I suppose I'm interested in how the cluster is going to address the issue of warranted variation. So we often in conversations with the NHS have talk about unwarranted variation, but I think one of the issues with a footprint as large and diverse as the DLN footprint is how the ICB cluster intends to identify those things that are appropriate to do the same across the whole footprint and those things which are appropriate to do differently across the footprint, because the footprint is a very varied footprint. I mean, even Lincolnshire is not a homogeneous whole, let alone the whole of the patch. So just interested and recognising the ICB is an emerging organisation, but it'd be really helpful to have a sense of the direction of travel there.
Sure. So I can understand exactly where that question is coming from. I think the balance to this is establishing exactly what you were just alluding to in terms of what is done at cluster level, what's done at county level, and what's done at place level. And clearly there's some, in terms of what's done at cluster level, it's majoring on those things where we can leverage the economies of scale and improve efficiency. And bringing together our collective assets. So when we've been developing this population health strategy and strategic commissioning plan, it's underpinned by a whole wealth of intelligence in terms of both population health management information and also citizen engagement and feedback that's been collated over the last few years. Helpfully, there is quite a large degree of commonality across the three counties, and also with early days, but we're starting to benefit from some counties being stronger than others and bringing particular strengths to the partnership. So there's very much a benefit there. This detailed analysis in terms of population health need has highlighted exactly what you were talking about in terms of the differences. And actually, one of the frames we've used to understand the cluster's population is actually one that leans very much into the framework that the Lincolnshire Director of Public Health's report, I think it was 2022, in terms of understanding our different types of communities. And we're very much looking at the different health needs in terms of different populations, in terms of whether urban, suburban, market towns, rural and coastal. We've also this is groundbreaking for the NHS, but not for the world at large. But we are focusing in on the concept of proportionate universalism. So understanding where there need to be sort of universal levels of services, but also understanding where there is greatest unmet need and poorest outcomes and lowest access, and responding accordingly. So we're maximising our collective resources more effectively and efficiently than we are at the moment. And a final point, that the guts of our population health strategy is developing neighbourhood health services, and the two dimensions of that in terms of not only getting the NHS services in order and how we work together with statutory services, but also in terms of how we work with other partners in the community in terms of, particularly in terms of the sort of prevention, proactive and wider determinants agenda. And I think that's where so there's going to be, I suppose in summary, there's going to be sort of cluster level work where appropriate, but the engine room of delivery is going to be at a neighbourhood level.
Thank you. Derek Ward, I believe you'd like to say something.
Yeah, I was just going to pick up on Fergus's last point there, actually, about the neighbourhood health approach. We were due as a Health and Wellbeing Board to receive an update on where we were with neighbourhood health across Lincolnshire as sort of those delivery blocks, with the ICB becoming clustered and being really a focus on commissioning for outcomes, and then the variability about how to achieve those outcomes is starting to be articulated by the neighbourhoods, and the board will remember that we've agreed in principle those neighbourhoods, although the language is wrong, will start and coalesce around our primary care networks in the first instance. Unfortunately, the national guidance hasn't come out, so we've had to push that back. But certainly over the next couple of months there should be more detail on that, and the Health and Wellbeing Board will receive more information once we've got it.
Thank you, Derek. Councillor Woolley.
Thank you, Chairman. Can I just check with you, Fergus, that at the NHS reform bill, which I understand is going to be out around mid to end of April, is the bill that will do away with NHSE, will do away with Healthwatch, will do away with ICPs. But you did mention that it was, this plan had been formed at the behest of NHSE. We're not going to have to do another plan, are we, once they're abolished?
My understanding is, Councillor Woolley, that we're sticking with the population health strategy and strategic commissioning plan from a DLN cluster perspective, and they'll be refined on an annual basis.
Thank you. Emma Tatlow.
Thank you, Chair. Thanks, Fergus. That was really useful to hear. I think it's more of a statement than a question, but it's just thinking about in terms of early prevention and activating the assets that we have within community and voluntary organisations across Lincolnshire, and bringing them into the conversation at the early enough opportunity so that they can help shape the plans and help what happens at a local level. Because our community and voluntary organisations, and there are infrastructure organisations with whom you can have conversations with, provide such valuable services, and we've got so much rich insight about what's happening at community. I genuinely think this could be an opportunity to create a step change in that relationship between the statutory organisations and the community and voluntary sector, and that the sector isn't brought in, you know, at the last minute or the 11th hour or when the plan's been decided, but they're actually genuinely part of the plan and embedded from the earliest opportunity. Because I think if we're committed to early prevention, the work that happens in communities can absolutely support the statutory services, and we're all committed to supporting health inequalities and better health outcomes. So it's just a plea really to make sure that strategically we're making those links at the earliest opportunity, and it feels like it's a co-created plan and approach for Lincolnshire and for neighbourhoods.
Agreed with that statement.
Thank you, Emma. Are there any other questions from anybody? Oh, Councillor Woolley.
Just the one. I mentioned about this reform bill that is coming out, and of course within that there's also the removal of local authorities from the ICBs, but with the inclusion then of the mayor. So what reassurance can you give us that at this neighbourhood local level there will still be that local flavour?
So we'll see what comes out with the neighbourhood guidance when that comes, but the direction of travel signalled in the 10-year health plan and the strategic commissioning framework is health and wellbeing boards will be driving the development of the neighbourhood health improvement plans, which will be where there's that leadership.
Would you like to come back, Councillor Woolley, on that? I see you.
Well,
nodding.
I suppose I'm being a little bit picky in that I hear you and I accept that, but I suppose my concern would be around the actual representation of the local authority. I know the local authority is represented on the health and wellbeing boards, but as just a single partner, as it were, I'm just concerned about that representation.
Karen Dunderdoe.
Thank you. If I might come in and assist Fergus with answering the question, Councillor Woolley. So the DLN board meetings that happen on a monthly basis have representation from the local authorities across the cluster, representing all of the authorities, as they do with health providers supporting across the cluster as well.
Sorry, Chairman, I would just like to come back on that. Really grateful for that explanation, but I think it's this business of when this a new bill comes in, there is the expectation of removing local authorities from, or reference to removing local authorities from ICBs. Does that mean that there will still be a choice as to whether you include local authority representation then when the bill comes in, not necessarily now, but later on?
Thank you, Chair. Thank you, Councillor Woolley. So I think that's something that as a DLN cluster board, from my perspective as the provider representative for Lincolnshire, is something that is yet to be discussed through the DLN cluster board meeting. And of course, it will be something that will be high on the agenda to work through. But currently, there is representation at the board meetings, and as far as I'm aware, will continue. Thank you. Thank you, Chair.
Martin Summers, you'd like to say something?
Yes, so thank you. So just carrying on this issue, and as Karen is well aware, I'm currently the Lincolnshire County Council representative on the DLN board, and very, very helpful to be at those meetings. Worth noting that the Derby, Derbyshire and Nottinghamshire local authorities have chosen to be represented at chief executive level to try to emphasise the connections to the local authorities as opposed to just adult social care. But more broadly, picking up Councillor Woolley's concerns, I think that issue about how the voice of local communities should be expressed on ICB boards is a very real one. As with Councillor Woolley, my understanding is that the bill, as currently drafted, does indeed propose to make that change, to take away local authorities from formal representation. Though, as Karen says, it's ICB boards will have the authority, I'm sure, to have other people in the room if they choose. But I think two things. One is that There are a number of organisations which are making representations to DHSC on this issue. Members of the Health and Wellbeing Board will be aware that I'm heavily involved with ADAS, my professional association, and we are making representation through that to DHSC. What the draft of the bill currently says and what it will say at the point where it's published may be two different things, and of course the bill will then need to go through its parliamentary process, and I'm sure that these issues will get fully aired, and of course DHSC ministers will listen carefully to the debate. So I think it is entirely appropriate to be raising these issues because we are still in process and there is every opportunity for issues and concerns to be heard and for appropriate responses to be developed.
Thank you for that, Martin. I'd just echo that. I think in terms of local authorities having a seat at the table, I'd really would like to make that point on record. I've been in Lincolnshire as well for myself for 20 years now. I think I'll get my passport in the next few years. But we're fiercely proud. Another aspect which has been touched on is the voice of Lincolnshire, which I'm pleased, Martin, you're although generally quietly spoken, I know when it comes to representing this county, your voice is heard loudly. And also what Derek, you were mentioning about sort of the term neighbourhood, and even within our very big county, it means different things throughout the county. So I just again concur with comments that were made earlier. So unless there are any more questions or comments, we've been invited, excuse me for my voice croaking, to note the requirements for the NHS Integrated Care Boards to develop a joint forward plan, to note the requirements for NHS Integrated Care Boards to give regard to local joint health and wellbeing strategy, or the joint health and wellbeing strategy, and to acknowledge that the DLN ICB cluster has produced a forward plan with regard to the Lincolnshire joint health and wellbeing strategy. So can I have a proposer? Councillor Cullen, and a seconder? Councillor Collier. All those in favour, if you could raise your hands, please. Thank you. Any against? And any abstentions? So that passes. Thank you. Right, so we now move on to item 6B, the Joint Strategic Needs Assessment Refresh. This item can be found on pages 19 to 32 of the agenda pack, and I'd like to welcome Alison Christie, Head of Prevention and System Oversight, to present the report. Alison.
Okay, switch on the microphone. So to supplement the paper that's in your pack, we have got a short presentation which I'm just going to run through, which details some of the developments and improvements we've done to the JSNA site. I'm going to refer to it as a JSNA because it's too long to say the full title. So can we have the first slide, Jess? So the JSNA is a collaborative evidence-based analysis of the current and future health and wellbeing needs of the local population to inform strategic planning and decision-making. So put simply, if you think of it as a bookcase that has lots of resources, intelligence, information about the health and wellbeing of the population of Lincolnshire. So it includes data sets like national data sets, registration of births and deaths, NHS and council services, local surveys, consultation information. So it's a big repository of information, basically. So the Lincolnshire JSNA is made up of 36 topics, and there's a list of the topics, I think, in Appendix A of the report. And we've arranged our JSNA using a life course approach, so they're allocated in terms of start well, live well, and age well. So just to give you some highlights of where we are with the review. So of the 36 topics, 29 have been fully reviewed and published, so they're live on the site now. That includes the two topics of financial inclusion and housing standards, which have only had a light review at this stage because we're aware that there's new developments coming online in the next couple of months, and it made sense to postpone or delay that review until that information was available, as we'll only have to redo that again. So we've sort of taken the decision to just make sure the data's up to date, but to do the full review in the coming months once we've got information on the Crisis Resilience Fund in terms of the financial inclusion topic, and the housing conditions survey in terms of the housing conditions topic. But they will be done in the next few months and republished. A further 6 reviews have been completed, but they're in the process of being uploaded onto the system. So they will be done in the next week to 2 weeks. They will be live. So all the reviews technically have been done, apart from neurological conditions. So neurological conditions covers conditions relating to damage to the brain, spinal cord, and peripheral nerves. So it includes conditions like motor neuron disease, Parkinson's disease, migraine, and traumatic brain injuries. Information on strokes, cardiovascular, and dementia are covered elsewhere in the JSNA. So due to the low numbers of instances of these conditions in Lincolnshire, we have consistently struggled to update this topic. In 2017, we commissioned the University of Lincoln to do a health needs assessment for us, which forms the basis of the current topic that's live on the website. And that's based on estimated data, so it's not based on real data. We have sought to update the information, and we're lacking robust, reliable data sources to make this topic meaningful. So one of the recommendations to the board today is that we actually remove that topic from the JSNA. Okay, next slide, please. So just to remind the board that the JSNA is a statutory responsibility of the Health and Wellbeing Board. And I say it provides that shared evidence base for partners to use. And the purpose is to encourage and embed collaboration between system partners and to work together to deliver the best health and care services based on the evidence. And it underpins our joint health and wellbeing strategy. I think alongside the JSNA, so that's based at population level, so it's at Lincolnshire level, Public Health do produce a number of other resources which sort of break that down into lower geographies. So we produce some profiles which are also on the Lincolnshire Health Intelligence Hub that look at district level information, at PCN level profiles. And as part of the neighbourhood health work, we are intending to then produce neighbourhood profiles that will help localise some of the information around common health issues, how services are used, and the differences between the different neighbourhoods that then local teams can use to inform what needs to be put in place locally to fit the communities they're serving. Next slide. So I say this is an online resource, and we've had it as an online resource probably since about 2016-17. Before that, it was PDF documents or a sort of published hard copy document. But for about 10 years, it has been an online resource. It started off as a static website, but we have over the years made it more automated and more interactive. So some of the improvements we've made, firstly to the home pages, is to produce some sort of interactive live sort of dashboards or infographics like the one shown here. And underneath that, there are 10 key points against each life stage, which helps summarise what's in all of the topics. So we've put a particular focus around inequalities and the core 20 plus and the 3 shifts in the 10-year health plan from hospital to community, from treatment to prevention, and from analogue to digital. And I think there's an example in Appendix B of the sort of overarching what the infographics look like. So there are a series of resources that users can download, they can use them in whatever reports and things that they're wanting to use. So, okay, so we tried to make it as user-friendly as possible. Okay. The other thing we've tried to do is sort of like simplify and streamline the topic pages. So previously we had the data sat at a side and you had to click on that separately and then look at the narrative, and it was a bit sort of clunky. But now we've actually embedded the graphs and the charts into the narrative so that the narrative flows with the data that's shown, and it sort of makes it a lot easier for you to use the information and to understand what it's been said. We've also added date stamps so people can know when it's the latest information. And as I say, we've also, again, looked at that inequalities and the 3 shifts to make sure that they're actually accounted for in the narrative. We're also conscious that a lot of these changes will be new to people, so we've created a series of user guides to help people navigate the site. I don't know if people have actually gone in and looked at the JSNA website, but there's a huge amount of information on there. So hopefully these guides will help people navigate it, be able to download and export the information. And also there's a facility to provide feedback and ask questions if people are stuck or can't find what they're looking for. So as I mentioned, the JSNA is the evidence base that we use for the Joint Health and Wellbeing Strategy. So in 2023, we developed an evidence-based prioritisation methodology using this grid in terms of trying to prioritise the 36 topics that are in the JSNA, because it's difficult to, when you've got things like a condition like cancer, to then assess how does that fit with housing. So we needed to have some sort of methodology to try and identify what would be our priorities. And this methodology maps all the topics in the JSNA according to their relative impact and the ability of partners to influence the change based on the potential impact on the population against the current direction of travel, i.e. was it getting better or was it getting worse? So we've reapplied that methodology to the updated JSNA just to validate whether our joint health and wellbeing strategy is still current, whether the priorities in it still apply. So next slide, please. So this is what it was in 2023, and the areas highlighted in orange are the priorities that we picked in our joint health and wellbeing strategy that we currently have. So you'll see that some of the ones in the far top right-hand corner haven't been picked as priorities. In deciding what we included in our joint health and wellbeing strategy, we considered what were things that needed a partnership approach. So we didn't pick anything that was a sole responsibility of one organisation. They had to have a partnership element to them. And also things that were not already being looked at elsewhere. So there were a number of those areas, for instance, drug and alcohol, that there is already a strategic partnership looking at that. So we need to consider that what's the added value of having the Health and Wellbeing Board looking at it as well. It's a bit of duplication there. So we picked those things that we felt that the Health and Wellbeing Board could add value to and that needed to have a partnership approach. So now we've rerun that exercise. Next. So this is based on our updated JSNA where the sort of topics come out using that methodology. As you can see, fairly similar in terms of the spread. So physical activity has moved from high burden worsening to high burden improving. Dementia has shifted from high burden worsening to high burden improving. Some other areas which potentially have moved is domestic abuse, which has moved from low burden improving to low burden worsening. Children in care has moved to improving to worsening. I think overall, where we are currently in light of the pending guidance around neighbourhood health, I think we can assure ourselves that some of the priorities we have are still valid. And I think we need to perhaps think about, once we have the guidance and understand what's happening in terms of neighbourhood health and how the joint health and wellbeing strategy fits with that, take a view then on whether we actually look to do a full review of the strategy. It was our intention sort of 18 months ago when we started the JSNA review that we would be reviewing it this year. But my recommendation would be that we sort of just wait for that guidance first before making that decision if the board's comfortable with that. Next slide, please. Yep. So we're conscious that we did the last major review in 2022-23, and we're conscious that nothing happened then for a couple of years. So we've tried, we're wanting to put in place a more robust process for ensuring that the data and information is kept up to date, because it's going to become increasingly important with things like neighbourhood health and everything to have the most up-to-date data. So we're proposing to put in place a 3-year rolling refresh programme. So this would mean, for instance, a topic would get a light retouch in years 1 and 2, but then a full retouch in year 3. So we're proposing to do it on a thirds basis. So a third would have a full refresh, and then the next 2 years would be light, and so on. So we ensure that every 3 years, every topic would have been reviewed, and that any of the new data and new information will be updated as part of a light touch refresh. Final slide, please. Obviously, it's only useful if people know about it. So we're conscious that we need to do some sort of promotion of the JSNA. So when we did it a few years ago, we held a series of webinars. So we're proposing to do that again and perhaps have some recordings on the website that show people how to use it and the benefit and use of it. But we're willing to come and present at any meetings that anyone has. And we're looking to perhaps put together more of a newsletter type communication to let people know when there is new information added to the JSNA. It is joint, so it is not just the sole responsibility of public health to do this. We facilitate it on behalf of the system, but it is really important that everyone, all partners, get involved in this, and that's, I think, the beauty of having it under the Health and Wellbeing Board, that everyone has that shared ownership of the JSNA. You know, we're happy for anyone. We've got a feedback loop, so if anyone wants to give comments or suggest things, then we will look at it. Bearing in mind we only have finite resource to support this, so you know, I say it is a shared resource, so it needs to be used, and we'd encourage partners to make sure that they use it in their sort of decision-making processes, that they use it when they're sort of writing their plans and things. You know, it is there to be used, and it is publicly available. Okay, thank you.
Thank you, Alison. It's a refresh, but it's also refreshing. I've visited the website, and I have to say it's actually really quite straightforward to use, and obviously we would encourage people who need to use it. I was also pleased that you mentioned about with neighbourhood health plans and so on, bringing it down to that sort of that level, bearing in mind where we are. So I'll now open it up to questions. Councillor Cullen.
Thank you very much, Mr. Chair. Just a comment, really. I want to echo the Chairman's comments regarding the ease of use of the website, and want to congratulate you on making it so user-friendly. So thank you very, very much. You've answered my question, which I was going to ask on the how people will be able to access the information. So thank you for that as well. And yeah, any help I can provide in, greater access, providing greater access to people, please don't hesitate to let me know. But thank you.
Any other questions? Derek.
It's not a question, it's just a comment to say that given the development of neighbourhood health, really useful to recognise that on the Lincolnshire Health Intelligence Hub, we already have primary care network profiles, and we're using primary care networks as our building block, so there's a lot of detail there already. There may be some changes around the edges, but in terms of as neighbourhood health develops, and picking up Councillor Woolley's point about differences across the county, that's already described to some level of detail using those PCN profiles, so that's useful from a change from an NHS perspective. The other thing that's useful is there are also district council profiles. So as local government reform plays through, there's also quite a lot of analysis there at a district council level for a building block for whatever MHCLG comes back and says should be the unitary model across Lincolnshire as well. So we've got quite a lot there already. It won't be perfect, and it will need to develop over time. But as Alison's articulated, we've built in a plan where we will have a roll-in update process anyway.
Martin Samuels.
So really, just rather than a question, a quick statement about, I think the report notes that all of the organisations that are sort of formally members of the Health and Wellbeing Board have a statutory duty to have regard to the JSNA. And I think one of the things that Alison has very helpfully brought out is we may have a statutory duty to have regard to it, but it's actually just so full of information and insight that I think we'd be mad if we didn't. So yes, there's a statutory duty, but I think we've got something where it is so well presented and so robust in its approach that actually it's something that we should be all running toward to want to use, even if we didn't have to use it. And I think that one of the strengths of the JSNA is the way that it is so robustly based in the evidence that all too often we can have conversations and debates, and I'm not using the word arguments, between partners about, well, what is the position? Well, I think the JSNA, by giving that evidence-based single view for the whole system, allows us to have that shared understanding that we start from the same place. Even if we might then have different views about what we should do afterwards, but at least we're starting from the same place in terms of the evidence, and that's a real strength and really does take take the system forward. So I think strongly to be welcomed and supported. So and recognising this doesn't happen by accident. There has been a great deal of work to pull this together, and I think the quality of that shows through on every page.
Thank you, Martin. Councillor Woolley?
Thank you, Chairman. Did you use fingertips to help with this data and compiling it?
Yes, it's one of our data sources, yeah.
Right. So what I'm slightly concerned about is that if we're using fingertips as a marker to say, here are the issues that we believe are the most important, on the latest fingertips for this local authority, both the amount of physical exercise and obesity are some of the worst in the country. But yet and I don't expect you to answer this because you didn't vote on it, but what I'm getting to is that, of course, the Integrated Lifestyle Service has now removed physical activity and obesity as areas that we should concentrate on as much as others. So I'm puzzled. How much weight can you put on using this information?
Alison, would you like to just briefly come
It's
back
an
on
evidence base, so it's there to inform the decision making. Obviously, it won't make the decision. That's up to whoever makes the decision, but it's there as an evidence base to inform it, and that's how it should really be used. Yeah.
Emma Tatlow?
Thank you. I think Councillor Willie made a point around physical activity, and I was quite surprised to see the significant shift in physical activity, because I don't think that aligns with our insight and information, and therefore, yeah, it might just be something we can have a conversation about to see how the data's stacking up, because current funding coming into Lincolnshire has been based on the fact that we have some of the most inactive adult populations in the whole country. So it doesn't feel, from the perspective and the information that we have sight of, that there is such a significant shift in physical activity levels. So I do think it's just worth us kind of sense checking that information. And the other point I would make, despite having said that, I completely agree, it's a very valuable resource, and I just think for more people and organisations to know that outside of this board is exceptionally helpful, because quite frequently we're hearing all sorts of people saying that they're building databases and they're looking for information. So there might just be a bit of a disconnect outside of some of the bigger statutory organisations in terms of people's knowledge and understanding of it. And my final point would be, is there an opportunity to add some further insight, more locally specific? So I was just having a flick here on some of the communities of interest, for example, and ethnic minority communities. I think we've got a huge amount of more Lincolnshire bespoke data and insight about minority ethnic communities, specifically in Lincolnshire, and their experience of the county, that could add a local flavour to what otherwise are some kind of more national reports and so on. I don't know what kind of threshold you have to have, if you like, in terms of the reports that you're prepared to include on here. But yeah, I just think there's probably an opportunity to deepen the connections with some of that real local insight.
Obviously, it's a process of improving every time we republish. And we do, virtually every topic does have a group that sort of owns it. So we work with partners to update the topic and gather the information and intelligence. Obviously, it's only as good as what that group gives us. So yes, there is every opportunity to add further stuff to it. You know, if you want to drop us an email and we can have that conversation about how we add that and how we could then build it into the next time we refresh it, certainly, yeah.
Thank you, Alison. Actually, just looking at that prioritisation matrix, and there have been some moves, and I take your point, Emma, about maybe doing a sense check on some of those within it. I see carers has gone into high burden, high worsening, and having just recently attended last month the carers innovation workshop, I'm hoping things like that will help move that in the opposite direction towards improvement. But have you got any thoughts yourself, Alison, on what else we could do there?
Actually, it's stayed pretty static from where it was in 2023, but I agree it is still quite high. And I think everything that's done through the priority, obviously carers is a priority in the joint health and wellbeing strategy. So I think it is about that, how we progress that priority and work in partnership to push that forward. Yeah.
Thank you, Alison. Derek Ward.
Just to come back about carers, but as an example of the prioritisation framework, I think the prioritisation framework was brought in to give sort of a visual overview of where we were. We've got to recognise the demography, geography and other unique components of Lincolnshire, so as the board is fully aware, we've got a significantly older population overall than the country on average and certainly the region, and it is ageing quicker due to a number of reasons. That therefore drives certain parts of the JSNA, because that's the underlying data, if you like, and that's part of the carers issue there. You know, you can go faster, but actually if the rug's being pulled out from under you even quicker, you're going backwards, aren't you? So the prioritisation framework and the matrix is useful to look at, but you do need to go a bit lower, and obviously Alison and I'm sure Trudy going forwards will make sure that the board have that depth of understanding. One of the other things that's always quite difficult is comparing different indicators against each other in terms of total burden, and we've used different methodologies, for example global burden of disease, to try to do that, but there's always going to be some decisions that the board will need to make.
Thank you, Derek. Are there any other questions or comments? Trudy Grant.
Whilst you've got two DPHs in the room, I'll take my opportunity, if I may, because as you can imagine, applying for this job, I've looked at this in quite a lot of detail, and I have to say it is a brilliant joint strategic needs assessment, so all credit to the team. It really is a good one. I've looked at many, and this is a good one. The one thing that really jumped out at me was the difference between life expectancy and healthy life expectancy, and I 22 years for females and what was it, 17, 18 for males, you know, significant, and actually if we really got underneath that data, then the difference in different groups of the population will be even greater. And I think if there's anything that we need to do going forward, it's absolutely to make sure that we're focusing on healthy life expectancy rather than life expectancy now. And in particular, looking at the inequalities in healthy life expectancy compared with life expectancy. So for me, it's a brilliant JSNA, absolutely brilliant. I really enjoyed looking at it, but they were such standout figures to me that, and I'm sure you've discussed them lots, but they really substantiate the need for us to look, when it comes to looking at the outcomes framework, particularly for the NHS, you know, healthy life expectancy is where it's at.
Thank you, Trudy. I absolutely agree. Healthy life expectancy is where it's at, and I look forward to us working together on that. Mark Jones.
Yeah, thank you, Chair. I think one of the things that we need to get better at as Team Lincolnshire, when we get really high quality data sets like this, really good information, is to bring it together with other similar documents from other pieces of the jigsaw, because we often find that the same people that are struggling with health inequality are also in the same area that's dealing with low academic attainment or high crime areas or any number of other issues. And I think one of the things we're very good at in forums like this is talking about this, rightly so. But then I think what we need to do is get better at going upwards and outwards and saying, well, where is somebody bringing all of this together? Where, if we suddenly have the ability to bid for funding for Lincolnshire, or indeed where should we focus the money we already have, I think we start looking at place-based budgeting in a much stronger way. We start impacting lives in a much more meaningful and long-lasting way. You know, if you're dealing with people from cradle to grave in the areas in which we know there's particular challenges, we're much more likely to have that longer-term impact. So, great piece of work. I just want to make sure we get the best possible value out of it, and I think that's something that certainly as County Council, PCC and other organisations we could probably do to take it and look at it more holistically with other documents.
Thank you, Mark. No, I totally agree. We need to work as closely as we can as a team, really, in addressing this. Are there any other questions or comments from anybody? Well, thank you very much. That was a very interesting discussion. And just to complete this item, the board is invited to note the refresh of the Joint Strategic Needs Assessment, and I'd like to put on note my thanks for the hard work that's been done in doing this. And the second point, to agree to the removal of the neurological conditions topic. So do I have a proposer? Councillor Collier, and a seconder? Councillor Cullen. For all those in favour, if you could raise your hands. Any against? Any abstentions? Thank you, that's been agreed. So we now move on to item 6C, the Lincolnshire Better Care Fund. And this item can be found on pages 33 to 42 of the agenda pack. And I'd like to welcome Martin Samuels, Executive Director for Adult Care and Community Wellbeing, to present this report. Martin.
Thank you, Chair. So I'll introduce the report. If there are difficult questions about the data and the annexes, then I have Paul Summers here, who is the expert on those things. But if I'll say a few words, and then if there's anything critical that I've missed out or garbled, then Paul can come in. So members of the board will be well familiar with the Better Care Fund. It's been a feature of our lives now for about a decade or so. So really, this report is in two parts. The first part is the Q3 reporting on the delivery of the 2025-26 Better Care Fund, and I'll say a couple of words about that in a minute. But the main part of the report, really, I think for today's purposes, is to give a bit of an update on where we are with the future of the Better Care Fund. And the key point there is that there has been a lot of conversation already at today's meeting about neighbourhood health. And I would just note in passing that while officially it is indeed neighbourhood health, the Minister for Care himself always refers to it as neighbourhood health and wellbeing. And I will do that myself, because actually this isn't simply about the delivery of health care. This is about enabling people in localities to have the best possible experience of life, and well-being is a key part of that. So there have been lots of references to neighbourhood health and well-being, and members of the board may be aware that the intention nationally is that the Better Care Fund should be significantly redesigned so that it effectively becomes the joint funding arrangement to support the implementation of neighbourhood health and wellbeing. In the report, it talks about the possibility of it being renamed the Integrated Care Fund. I have a feeling that was actually, no, it was the transformation, the integrated transformation fund was what it was originally going to be called 10 years ago. We'll see what it actually gets called. So we've been expecting guidance on the revision of the Better Care Fund for some time, expecting that to come in parallel with the guidance on neighbourhood health and wellbeing. Members of the board may well be aware that the national guidance on neighbourhood health and wellbeing is not yet ready for publication. I'll put it in that gentle way, and therefore Department of Health and Social Care (DHSC) recognised that we couldn't wait for the Better Care Fund updated guidance. So in fact, what they've done is they've separated the two. And we have just quite recently had the guidance for the Better Care Fund for 2026-27, and Paul may correct me on this, but it is largely a roll forward of the existing guidance. So effectively, DHSC, having not been able to reach a firm position on neighbourhood health and wellbeing in time for the current the financial year that's about to start, has essentially taken the view, let's keep the Better Care Fund going, and we will then come back to that for the 27-28 revision. So we are expecting a major revision for the Better Care Fund, but it'll now be in a year's time. We are expecting, when that happens, because of the focus on neighbourhood health and wellbeing, that it will have a particular focus on intermediate care. And I think one of the things that comes from that is that we've previously had conversations at this board about the Lincolnshire arrangement for the Health and Wellbeing Board, where, as members of this board will be aware, we have voluntarily put mental health and learning disability budgets into the Better Care Fund, and that makes the Lincolnshire Better Care Fund one of the biggest in the country. We did take the view early last year that this probably didn't really fit with the direction of travel of the Better Care Fund, with its emphasis on intermediate care. We held off making any significant changes at that point a year ago, because we were expecting the neighbourhood health guidance that would transform the BCF. I think, given that hasn't happened, we will need as a system to reflect on whether we should make changes for the 26-7 plan in terms of mental health and learning disability, or whether we should continue to roll that forward for another year. We'll have conversations about that, but it does mean that I just invite the board to be aware that when we do bring the plan to a forthcoming meeting, we will have had those conversations, but it'd be something that'd be worth the board having a conversation about. But so effectively, although I've recognised I've spoken for a couple of minutes now, the summary is not much change to the BCF planned for 26-7 from a national policy perspective. The report in front of you does give an update on the Q3 return for the BCF. 3 out of the 5 metrics have been achieved. They're set out at the bottom of page 34. There are some areas where we need to do some further work, and colleagues across the system are working on those. I think I'll probably stop there. If anyone has questions on the detail of of those areas where we are having to do some further work, I'm sure Paul would be delighted to answer them. Thank you, Chair.
Thank you, Martin, for that. I'm just interested to know if and maybe this is a question for Paul, in terms of how we compare with those metrics, with the sort of national picture, or even with our neighbours.
Yeah, so I think in terms of our neighbours and our peer group, we're kind of around the middle with the majority of those metrics in particular. However, it's worth caveating, and I did say this in the report, that the data's often out of date. And I attended a metrics webinar today on data for 26-27, where they have promised us that we'll have almost like a month behind rather than 3 months, which are at the moment, which will then allow us to look at our peer groups, but also other areas at the same time to see where we are.
Thank you, Paul. Do I have any questions? or comments? Karen Dunderdale.
Thank you, Chair. Thank you, Martin, Paul, for offering us the paper on the BCF. And it was really helpful to hear the conversation, Martin, about how the BCF will change. We kind of think we know how it's going to change, but it's yet something that we're still working through. But of course, in Lincolnshire, we've always worked really well and closely together. And I think as we get to understand exactly what the BCF will become, sister brother of, will be helpful to understand that for the residents of Lincolnshire, and also will strengthen how we work collectively and collaboratively together. Paul, your point about the data is out of date by some 3 months is a point really well made, and one that we need to take notice of, because of course across healthcare services things move very, very quickly, and 3 months out of date may as well be 3 years out of date for us. So again, as we work together and strengthen the data and the way that we work and how we think about what is currently the BCF for the residents of Lincolnshire, I think that can only be of benefit to everyone. Thank you.
Thank you, Karen, for that. Martin Samuels, sorry.
So I just quickly wanted to respond to one of the points that Karen made. So the Better Care Fund is by definition intended to be a system partnership approach, and we have sought to approach it in that way. However, I think it's clear that with the changes in the system that are coming through from the changes to the ICB, the work that's bringing the community trust and the hospital trust ever closer together, and obviously all the work that's being done about neighbourhood health. Absolutely, one of the things that we need to do is to look at the way in which we govern and operate the Better Care Fund in terms of the teams that operate beneath this board, and to make sure that we are properly up to date in terms of who should be around the table, how should we be working on that, just to make sure that it properly is a Lincolnshire system plan that can be properly owned and understood and guided by the Health and Wellbeing Board. So I think there is always work to be done on that, but I think I think Karen has rightly reminded us that we need to bear that in mind.
Thank you, Martin. Do I have any other questions or comments from anybody? In which case, the board has been invited to note the update on the Better Care Fund for Q3. Can I have a proposer, please? Councillor Cullen. And I will second that. So if I could ask you to raise your hands if you are in favour. Thank you. Any against? Any abstentions? Thank you. That's been agreed. So if we now move on to item 6D, this is the Director of Public Health annual report for 2025, the public health case for quality employment. This item can be found on pages 43 to 80 of the agenda pack, and I'd now like to welcome Derek Ward, as still the current Director of Public Health, to present the report. Thank you, Derek.
Thank you, Councillor Clegg. We've got a slide deck, so I'll run through this with apologies to people who've seen this already, because it is required to go through a number of different meetings. I'll try and pull out selling points, and happy to have a conversation at the end of it. Each year, Directors of Public Health have a statutory responsibility to write a report describing the health and wellbeing of the population they serve, and we take different approaches each year, as you'll be aware, and each year the Council has a statutory responsibility to publish the report. So this is the sort of final stage of going through that process to cite everybody. Next slide, please, Jess. If you take nothing else away, the relationship between good health and good employment and poor health and bad employment is the thing to take away, and that it is either a symbiotic positive relationship or it's a negative downward spiral. And the report outlines some of the evidence to support that, provides a description of how that plays out in Lincolnshire specifically, and we'll come on to some of the maps that the board will be aware of from previous reports, and then outline some of the key things that we can do collectively as a partnership, which has come up a few times, to play into that, and to pick up Trudy's point about healthy life expectancy. Good employment, good jobs are one of the key drivers of the healthy life expectancy approach, and then poor life expectancy and poor healthy life expectancy are often tied to poor employment for a number of reasons as well. Next slide, please. So at the moment, some members of the population of Lincolnshire experience what is clearly a vicious cycle when it comes to employment and health, and what we need to do collectively is translate that into a virtuous cycle of health and employment. And I say health and employment, but it could be in employment and health. They are very much interchangeable. And the history of public health, actually, you can go back to Greeks and Romans, was around trying to keep people fit and healthy, to either fight wars or to generate income for city-states. So this is an absolutely embedded focus for public health professionals. It's not a nice to do, it's an absolutely fundamental part of what we do. I often talk about what the previous Chief Executive of Public Health England used to talk about. To keep somebody fit and healthy, we need a home, a job and a friend. Obviously this fits in the job space. Next slide, please. Our employment challenges are really Lincolnshire's challenges. There's nothing in there that really would surprise anybody, I think, across this board. We are large, we are rural, we are coastal, and we are dispersed as a population. To some extent, that can be a real positive, and we talked about that previously in terms of access to blue and green space is really good. But in terms of employment, it can cause real challenges, and some of those challenges are very structural in terms of transport and access to major areas, and we'll come on to how that plays out with some of our districts and the challenges there. We've talked already about our ageing population, high levels of long-term conditions. Long-term conditions in and of themselves do not necessarily drive unemployment or lack of ability to maintain employment. There is a very clear relationship between employers and how we change how we support people with long-term conditions and whether we can keep those individuals in employment. And we also have the flip side. Lots of employers really struggle to recruit and maintain a suitable level of employment to flourish as businesses. And so there is, again, a potential virtuous cycle there rather than a downward cycle. In terms of the employment factor, I should have said at the beginning, actually, I'm really grateful to Andy Gutherson. This is a joint report that I did with Andy Gutherson as our Director of Place, our Executive Director of Place. And we've got quite a lot of data around employment and employability, a lot of data around transport that fits within Andy Gutherson's area. Previous Directors of Public Health and reports that I've done have been with the previous Director of Adult Social Services, Director of Children's Services around different areas. So thank you to Andy for that one. And some of the data on this slide comes from Andy's team about where our major employment sectors are. And its foundational sectors in Lincolnshire dominate. We're not the City of London, and health and care, retail, tourism, and agriculture are obviously really, really important to the county, and that plays through into seasonal and low security employment as well. Next slide, please. For those of you who've been around for a little while, or you've had a look at previous DPH reports, these maps may look very familiar. Certainly the map around deprivation is one that we pretty well include in every DPH report because it's such an important driver of health and ill health. But what you'll see there is an inverse relationship between, you'll see a direct relationship between economic inactivity and long-term illness. So that's that in this case, negative relationship, but you can flip it on its head and say where people do have good employment in positive roles, then generally long-term illness is lower. And all of that is described in the report. Next slide, please, yes. I'm going to whistle through this because it will give us time to have a conversation. The key drivers of ill health. Now, this is long-term condition. I'll come on to more short-term conditions in a second. Key drivers of long-term condition, and this came up in the report that we did a few years ago around the global burden of disease. Musculoskeletal, bad backs, bad necks, bad hips, bad knees. These are really, really important in terms of long-term conditions, and they are even more important in terms of the impact on people's ability to secure and maintain employment. So MSK, musculoskeletal conditions, really, really important. Mental health or mental ill health is absolutely vital in terms of we need to tackle that to keep people in work. Generally, we see another downward spiral with low levels of anxiety or depression, sometimes leading to people taking time off sick. They may be signed off. Through that period, they may not exercise, their mental health may deteriorate, they may start to put on weight, and that downward spiral does actually develop, and we've seen international and national and some Lincolnshire level evidence that shows that downward spiral. So it becomes a question of, for people with musculoskeletal conditions or deteriorating mental health issues, how do we maintain their employment so that they don't start that downward spiral, whilst recognising that these are medical conditions and they do need to be treated in the right way, and we need to maintain people in suitable employment. Cardiovascular disease, diabetes and respiratory disease tend to be key issues that we come up against across a whole range of different issues. The other thing that I'll add, it's not a long-term condition, is viral infections. You know, we often have a number of people in every workforce that will be off because of colds and flu and other viruses, and there is a general feeling that, well, I'm going to get a cold, I'm going to be off sick. There's almost an inevitability about it. I think it's important to flag up that it's not inevitable. Firstly, we know, and I've said it, I think probably in every health and wellbeing board in one form or another that I've been at, if you get all of your vaccinations, you are going to reduce the risk of catching or getting a virus that's going to stop you going to work. That won't be a primary driver, I'm sure, but it is important to make sure that if you are eligible for a vaccine, please make sure you get it. But also, if you've got, if you exercise, if you have a healthy diet, then you are going to have a much stronger immune system. It's going to reduce the risk of you catching viruses and even bacterial infections as well. So it's not inevitable. There are things that we can do that will protect us against viruses, as well as pretty well everything else on that list. Next slide, please. We've gone into the report. I won't go in here, but happy to pick it up in the discussion. We've tried to look at the intersectionality between different conditions, different geographies, and different excluded groups, and give us more of a three-dimensional understanding of some of the challenges that people experience in terms of good employment and good health, or poor employment and poor health. And there's some of the groups that we've picked out that face systematic barriers to employment. We've talked already about people with mental health conditions. Unpaid carers is also a priority for the Health and Wellbeing Board, and it is in the Health and Wellbeing Strategy, so really important to keep an eye on that one. They're all important, but I'd also flag up veterans. And one of the really interesting little side notes that I'll make now is I was very pleased to host the Chief Medical Officer for England about a month ago. We went across the county looking at different services, and we had lunch with colleagues in the Royal Air Force. And they were talking about their approach to servicemen and women who are active but have health conditions, and how they don't sign those individuals off sick. They will redeploy them into a different role. Could be fundamentally different role, especially if you're a fighter pilot, but they will keep people employed in active employment that meets whatever their health condition is, because it keeps that person in a working environment, and that's then easier for that individual as their health condition improves for them to transition back into their substantive role. Clearly, it's it's one thing when you're doing that in an armed service. It's another thing that you can't really do that in a micro company. But there are some very large employers across Lincolnshire, I think, that we could learn, and I say we included, in the county council could learn quite a lot from how the armed services approach supporting people with ill health and maintain their employment. Next slide, please, Jess. A few figures. Really important to recognise the scale of this problem. The cost, I'll do a cost and then a benefit analysis here. The cost of inactivity in Lincolnshire is estimated, it's an estimate of course, is estimated to be nearly £2 billion. That's not far off what the Integrated Care Board spends on health and care in Lincolnshire. So we are in effect spending the same amount, not necessarily purely from the NHS, but in terms of the economic cost to Lincolnshire. And then if you flip that down, and I'll look at the bottom line, 3.76 billion, society would benefit. And that's a really straightforward bit of maths. One, you're not spending 1.8 billion or losing 1.8 billion in terms of people being inactive. And secondly, those people who would have been inactive are now part of the labour force and are paying taxes. And that income, both taxation but also money in people's pockets to spend on the local economy, gives pretty well the same amount again, that 1.8 billion, which is where the 3.75 billion pounds, billion. So I hate billion because it's too easy to say. So that's 3,760 million pounds that Lincolnshire could benefit if we could tackle this completely. Don't for a second think we're never going to have anybody off sick work, but you can see where if we can affect a 5% change in that, these figures are huge. Next slide, please. Why is this a public sector issue? I've already mentioned, really, it's interested in whether Trudy agrees with me here. Always dangerous when you've got two professors sitting next to each other to ask this question, but I think there is a history within public health that meaningful work has been a real foundation of public health practice. But there are a whole range of other reasons, not least the economic case on the previous slide, that drive the importance of this particular issue. And of course, the Health and Wellbeing Board has a statutory responsibility around improving the health of the population of Lincolnshire. Next slide, please. I won't go into this in detail because it is in the report, but this isn't something that we can target one particular intervention in one particular place and we'll tick that box. We need a whole system approach. This isn't my language. This is sort of an emerging narrative around public health. Primary, secondary, tertiary prevention. How do we firstly get to call it primordial? I don't like that, but it's a language. How do we make sure our transport and our housing is fit for purpose so that people can get to roles, that they're not being made sick because of the quality of housing? How do we make sure our education in childcare is accessible so it allows people, working parents, to work whilst also helping children to thrive? That's a twin benefit. In terms of what can we do around healthy workplaces, we've got a pretty detailed and comprehensive offer as a county council at the moment, but there may be more that we want to do there and reduce our risks, for example, making sure that we get our vaccines. What can we do to identify ill health earlier, and how do we adapt the employment options we provide so that we don't expect the person to necessarily be signed off sick? We change the role so that they continue to work. And then when people maybe do come out of the labour market, what do we do to help them improve their health and well-being and then get back into the labour market? That's the overall approach. And we need to do work on all of those aspects if we are going to realise that £3.75 billion potential benefit for Lincolnshire. Next slide, please, Jim. In some areas, we're not too sure what works well. Not in this area. We know what works well. I've already given a little example about what the RAF does, and they are, I would say, on our doorstep, but they're not on our doorstep. They are here. So we can learn from a whole range of different employers. There have been there's been report after report about this is what works. If you look at some of the big Silicon Valley employers, they have wraparound health and care programs that make your eyes water, but it's financially beneficial to that company. You know, likes of Apple and Microsoft, they actually make money by spending money. It's an investment in their workforce. And yet, certainly in the public sector, we tend to think it's a cost. We need to refocus our thinking and see it's an investment in our employees that's actually a benefit to the council and the taxpayer. And we've got a whole range of different things that we can do there. Next slide. I've really covered a lot of this. We need to recognise that employment is a health issue and health is an employment issue. So if you take nothing away, take that one away. Next slide, please, Jess. And as ever with the Director of Public Health annual report, and I went to scrutiny recently with updates on recommendations from previous reports and what we've done. We've made a series of recommendations in this DPH report. It won't be for me to deliver them. I'll leave that to Trudy and others that come behind. But these are all, this is what we can do, and this is how, as a Health and Wellbeing Board, we should focus if we want to affect change. Final slide, I think it is. Final real slide. Just to return to the opening conversation, we need to turn that vicious cycle into a virtuous cycle. And there is a real opportunity, especially in a place like Lincolnshire, to do that. Thank you very much.
Thank you, Derek. Well, I've had the pleasure of hearing this report several times, and as I mentioned before the start of this meeting, every time I hear it, it just reinforces just how good a report it is. Very refreshing, and my thanks go obviously to you, Derek, but also to Andy Gutherson as Director of Place for putting it together. And I think it does you very clearly highlighted the interrelationship between good health and good employment, or whichever way around it is, and so on. If I can just ask one question, you've touched on this. You mentioned Silicon Valley. You've mentioned public sector and some of the larger organisations, but in this county in particular, we have a very large number of, micro businesses, which you've mentioned as well. What can we do realistically to help address this particular issue with them?
There are models where micro businesses come together in support packages. For example, there are models where the public sector will work closely with micro businesses to allow flexible labour market support. So if somebody's off sick, there may be the option to flex some workforce to cover that gap, but also to provide support for that person who is off via local leisure services, which obviously in our county would be a district council support mechanism. And I think we've just got to think fundamentally differently about how we approach it, whether it is generally and obviously easier in a big with a big employer to flex your workforce within the employment area in and of itself. But there are models out there that we could look at and adapt, and we need to work through chambers of commerce and other organisations, which Andy Gutherson's team have a really, really strong link in with, to facilitate that support.
Thank you. I mean, yes, I am a musculoskeletal therapist. I'm not declaring an interest here, but I have had cases where I've said to people, really, you need to take time off, or you need to do this differently. And those very, the one person band, they say, well, I can't afford it. So I think we do need to do what we can to try and sort of help steer these people in towards a sort of better, improving health for their benefit. Obviously, I've got Martin Samuels, if you'd like to come in now.
Thank you, Chair. So a couple of quick points. One is, although this is the Director of Public Health annual report, and obviously it jointly with Andy Gutherson, I think Derek's presentation, I think, really underlines how all of the organisations here represented at this board, we all have some of the pieces that have a substantial influence on people's quality of life and their well-being. And just looking at the issue of employment, all of our organisations play a significant role in different elements of it. So I think really the first thing I wanted to do was to sort of welcome the report by that it feels, although as Derek said, you've got a bit of a roadshow taking it to lots of different places, it feels perhaps particularly appropriate for it to be coming here to the Health and Wellbeing Board, given our collective responsibilities. And I think picking up a comment that Mark made earlier about the need for us to bring different sources of data together, for us to be thinking about things in a joint and coherent manner, I think that Derek's report is really valuable in helping us to do that. And then the second thing I wanted to note was that this is, of course, Derek's last Director of Public Health report for Lincolnshire. As has been sort of hinted at various times during the course of today's meeting, this is in fact his last week with Lincolnshire, and he'll be going, has been lured away to the sunnier climes of Norfolk. So I'm sure that the board would wish to express our collective thanks to Derek for the work that he's done in Lincolnshire, he leaves a very strong legacy, which I know Trudy will be picking up and carrying forward. But it's as I'm sure as a board, we are very grateful to Derek for all the work that he's done over the years that he's been with us.
Thank you, Martin. I completely concur. In fact, it's been a bit of a long farewell, Derek, because again, with every presentation of this report, I've said words similar. But again, thank you for all your contributions in your time as Director of Public Health for Lincolnshire. Melanie Weatherly.
Thanks. Thank you, Derek. Well, very interesting report. I was just wondering, with the Employment Rights Act coming in, whether that actually gives us a reason to talk to employers to say, sickness absence is going to cost you more. So now is the time, even if it's only get your vaccine done, to look at it differently. And I've noticed that the hospital is offering its occupational health services beyond itself, and maybe that's something we could work with. I do think this is the right, I know that's not the intention of the Employment Rights Act, but I do think it gives us the opportunity to have a different conversation, that ill health costs you money as a business.
Thank you, Melanie. That's a very good point. Councillor Cullen.
Thank you, Mr. Chair. Once again, Professor Ward, I thank you for the report, as I have heard it during the health scrutiny. I just wanted to repeat what I said then, that even though employees are, in theory, protected by the protected by the Discrimination Act, we all know that even though they might not voice it out loud, employers will choose the applicant that is healthy over the one that is not. So anything we can support and encourage employers to be more inclusive with their employing those that may not be as healthy as others I encourage fully. So thank you very, very much for the report once again, and I wish you all the very best in Norfolk. Thank you, Mr. Chair.
Thank you, Councillor Cullen. Emma Tatlow.
Thank you. Super interesting report, and some observations around when we've started to talk to organisations in South Holland, in particular, at the moment. Some of the larger organisations are able to have physios on site, and they can actually afford to have their own kind of medical and clinical expertise on site. Thinking about those smaller organisations and micro businesses, some of the work that we've tested has been around, for example, bringing MSK practitioners into community spaces and thinking about the shift patterns that perhaps people are working on and making them available outside of the typical hours. And this is absolutely, I think, a golden opportunity to think about that system-wide join up in a place, because we can bring together the private sector, the clinical expertise and the community centre services to actually make sure that we're providing a really rounded offer of support for people when they have particular conditions, but hopefully as well to think about that kind of early prevention piece as well. So I guess the question that I'm often left holding with a report like this is kind of the how then. You know, it is about the so what, isn't it? And it is how, as system partners and people who can actually influence and take away some actions from this, how do we genuinely work together in the 12 months ahead to start to influence change?
Thank you, Emma. That's some very good points. Derek.
Yeah, just to come back on that and to come back on earlier conversations we had around neighbourhood health, for example, real opportunity with local government reorganisation and the infrastructure, the buildings that the districts and the county council has, for example, along with the development of neighbourhood health, along with a focus on trying to either keep people fit and healthy, or if they are starting to experience musculoskeletal conditions, well, there's a real opportunity there to use local physiotherapists in local leisure centres or other settings to intervene earlier, and also give them the vaccinations at the same time, and potentially give them a bit of space to have a chat with others, which is going to help with connection and mental well-being. And then they may decide to stay on and use the leisure facility, and then you start to generate income to the local economy there. So it's just a way of thinking differently about those virtuous cycles, and trying to turn what would be a negative cycle into a potential positive. I think the place focus is going to be really, really important, and South Holland particularly, because it's right next to Norfolk. So I would declare an interest there.
Thank you, Derek. Do you have any other questions? Councillor Cullen. Collier. Sorry.
Yes, it's just going back to thank you, Derek, for your report as well. It's very, very interesting, very fascinating, and a bit scary as well, reading some of the figures, what's going on out there. I was a bit concerned as well, especially at a couple of points about the mental health, the highest rises the younger, the youth, and that. I'm very concerned about that, very concerned. And I was with a resident this morning who's got 4 SENS children. She has ADHD herself as well, and that's a huge, huge problem. I do hope that we're having some sort of in-depth look into what's going on here. One thing I was just going to say was, if we're putting these things in local areas, which is wonderful to have these local hubs for people to go to. We have a really fantastic diagnostics centre here in Lincoln now. I am a district councillor for Birchwood, which is a deprived area. I have a lot of residents there who haven't got transport. This diagnostic centre is wonderful, but there's no transport there. The nearest stop is quite a long walk. And if you're going to a diagnostic centre, there's a reason for that, you know. So it's that sort of thing needs to be put into place as well. It's no good putting things there, which are great, but how do people get there? Even if it's only just over the other side of their area, like, they've still got to get there. You know, from Birchwood, where I am, one side to the other side isn't far to walk if you're healthy, but it is if you're not. So I hope that further consideration will be put into place for how people will get to these places. Thank you.
Thank you, Councillor Collier. Do I have any other comments or questions? Well, that was a very interesting discussion. I'm very appreciative of people's comments there. So we are invited to note the contents of this report. May I have a proposer? Councillor Collier, and we'll have Martin Sanders as the seconder. So all those in favour, please raise your hands. Thank you. Any abstentions? Any against? No. Thank you very much. That's been agreed, and thank you again, Derek, and pass on our thanks to Andy Gutherson as well. Thank you. So we move on to item 7A, the action log of previous decisions. This can be found on pages 81 to 86 of the agenda pack, and this item is for noting. does any member have any comments to make? If not, and people are in agreement, can I just have a show of hands? Thank you, that is noted. Moving to the final item, item 7B, the forward plan. This can be found on pages 87 to 88. This item's for noting, and members are welcome to propose additional items for inclusion. Alternatively, if they prefer, they can contact Alison Christie directly to request an item be added to the plan. Do I have anybody who wishes to make any comments? Councillor Devereux.
Thank you, Chairman. Really only that I know we've offered before, but with the better ageing, if that could please make its way on, that would be most appreciated. Thank you.
Thank you. So I thought I saw somebody else's hand go up there. No. Okay. Thank you very much. So if I could ask members if they agree with the forward plan, if I could have a show of hands. Thank you. That item is noted. So that's the conclusion of today's meeting. Thank you very much to all of you who have attended and those who've obviously contributed to interesting set of discussions. So have a safe journey home. Bon voyage, Derek. And we'll see you at the next meeting. The rest of you, that is. Thank you.